upload them. So I think we've talked about the less than 100. I think it was the less than 100 I will stop. Then we're talking about the.
Yes.
Did we do the less than 100?
Yes, we did less than 100. That was where we stopped. We did not go to prior. Yeah.
Okay, okay, yeah. So prion disease are just they are caused by like conversion of a normal protein, normal prion protein to which contains the alpha helical form. So this alpha helical form and this beta pleated form, they are like secondary structure of protein. So proteins can exist in alpha helical form or beta pleated form. So majority of the proteins exist in the alpha helical form and they are stable. So prion proteins are um, kind of some proteins in the body that are formed when um, we have conversion from of some proteins from this. Okay, no. So there are some proteins in the body that are called the prion protein. So they become abnormal when they are converted from the alpha helical form to the beta pleated form. So these ones are more like um, they are like subclass of amyloid proteins too, but they are not amyloid protein per se. Because in these ones, you can actually transmit it from one person to another. So it's something you can see in your exam. They can make a scenario of this presentation, and they will ask you what is the abnormality. So, or they can ask you what is the normal structure the protein should exist in. Yeah. So that's a way they can ask that question. So normally the protein protein should exist in alpha helical form. So, but if in prior diseases, those protein now get converted to the beta pleated form, which is non-degradable, and in that form, they can be transmitted from one person to another. They can be transmitted by blood. They can be transmitted by surgical equipment. They can even be transmitted by eating meat from animals that have those prior proteins. So the point here is that prior proteins normally should exist in the alpha helical form. So they become abnormal when they are converted to the beta pleated form. That's when they aggregate and they start causing diseases. So there are some type that can be transmitted from one person to another by using surgical equipment. So if they have used surgical equipment of an individual that has this prion disease and you have this prion protein accumulating in the brain and causing damage, if that person gets operated on by neurosurgery and the surgical equipment that was used to treat that person is used on another person, you can transmit those prion protein from that person to another person. So that form is what we call the iatrogenic um, CJD. So that's what we call the Creutzfeldt-Jakob disease. Sorry, I don't know how to pronounce that stuff very well. So Creutzfeldt-Jakob disease. So the iatrogenic form. That's the one that causes the normal Creutzfeldt-Jakob disease when you have sharing of equipment and those things. And we know the way they will present. So they will just tell us there's ectaxial, there is um demential, there is myoclonus. So if you tell us, if once you see that triad, demential, ectaxial, myoclonus in an individual, you know that that is likely to be the iatrogenic CJD due to sharing of neurosurgical equipment that are unsterilized. So you are going to see spongiform vacuolation in the brain due to deposition of those protein in the brain. So they start making vacuoles in the brain, and there's no inflammation there. So it's just non-inflammatory spongiform vacuolation in the brain. And of course, if I'm trying to bring your neuro back, you guys remember that that's where you start doing your analysis, CSF analysis, looking for your protein 1433. That's where you see in someone that has this iatrogenic CJD. Protein 1433 will be present, and you see these spike waves, on ECG. Yeah, so then we have the food contaminated one that we call the bovine spongiform encephalopathy. So bovine spongiform encephalopathy is like more like a prion disease that occurs in animal. It occurs in animal. The way they typically present, we call it the mad cow disease. So bovine spongiform encephalopathy is known as the mad cow disease. So because animals that have this prion protein in their brain, in their system, they tend to behave abnormally. So they are agitated, they are salivating, they are uh, they are restless, they are not coordinated, they have improper gait. It's like they're having cerebral issues and all those things. So they behave irrationally. That's why they call them the mad cow disease. So an individual can develop something that looks like the bovine spongiform encephalopathy presentation when they consume animal products that are containing those paraprotein. So in that kind of individual, you say the person has a variant CJD. So The person can have dementia, the person will be restless, the person will be unstable, the person will have incoordination. Sorry, guys, sorry, I'm so sorry. Yeah, so they cannot move, they have abnormal behavior, irrational behavior, and all those things. So that one is due to consumption of animals that have this bovine spongiform encephalopathy. So any individual that takes in the meat from that kind of animal, the person will develop the variant form of CJD, the variant form of CJD, because the protein in that abnormal form can resist protease degradation, just like amyloid. It cannot be digested, so it just keep accumulating and causing problem in the brain. So we should not forget that the Jacob disease, which is this, then the bovine spongial encephalopathy, the mad cow. Then we have Kuru. Kuru is just like very similar to this bovine spongial encephalopathy, but it's just that we are not getting the plant protein now from animals. We are getting it from eating human meat. So people that are having these symptoms, incoordination, restlessness, difficulty in moving, dementia, you know, agitation, and all those things, following consumption of human meat like cannibalism, we call that kuru. So Creutzfeldt-Jakob disease, the iatrogenic one is when they get the plant protein from one individual to another by sharing neurosurgical equipment. So the classic presentation of that one is the dementia, ataxia, and the staturomyoclonus, which can progress to death. It's very rapidly progressive. Then we have the bovine spongial encephalopathy, which is due to consumption of animal that have those paraprotein within their muscles. And kuru is when you get that stuff from eating fellow humans, people that practice cannibalism. So that is that about paraprotein. Don't forget, it's due to abnormality in the secondary structure of the protein. They are converted from the normal, which is the alpha helix, to the abnormal form, which is the beta pleated sheet, that you cannot degrade, just like amyloid. So let's go to the microbiota system. So neonates that are delivered by cesarean section don't have typical commensals that colonize the vagina of the mother. So they have commensals that are located within the skin of normal individuals, because people that are delivered by cesarean section, the first microbiota that they're going to get exposed to are the flora that are present within the skin of the person that is doing the surgery and the person that is receiving them. So not the flora of the vagina. So that is that for neonates that are delivered by cesarean section. So what are the typical uh, flora in each location of the body? So the skin, we already know this. Staph epidermidis, that's the skin, very easy. In the nose, you have staph epidermidis too, but it can get colonized by Staph aureus. What it means is that when you say colonization, it means that you can find it there, but it doesn't stay there permanently. It's just for a short while. It will be cleared off. So a colonizer is different from normal commensal. Normal commensal or replace, they are permanently resident of that area. While colonizer just come, later they will be cleared off. So Staph aureus can also contaminate or colonize the nose. Oropharynx typically, once you see oropharynx, typically you want to think about the viridian strep, sanguines, mutans, mitis. But if they are being specific, dental plaque, it's still the variants, but most commonly mutants. Please don't forget that. Most commonly it is mutants. Although I know that USMLE they are not wicked. They will not put metis there or sanguinis there for you. They will still make it easy. But even if you see them, the one that should come to your mind first for dental plaque is the strep mutant. The strep mutant. They are part of the viridans too. But generally the viridans are located within the oropharynx. Then the colon, the Bacteroides fragilis, very important in the colon. Those are part of the anaerobes. Bacteroides fragilis, they are, large uh, occupants of the colon. Then you can find E. coli too, and other gram-negative, bacilli. They are there in the colon. So, but pay attention to Bacteroides fragilis in the colon. Then vagina, lactobacillus. Yeah, they can be colonized by group B strep and E. coli. You guys remember when we were talking about group B strep that we said, what did we say? We said we will screen the women between what? Who remembers? When are we going to screen those women?
35 to
That's
37,
probably
right?
36
Thank you, Dr.
weeks.
Olushola. We are screening that. So that means that if they are normal flora, do we need to be screening, guys? If they are normal flora, do we need to screen?
No.
No.
No, because we will definitely find it there. But they are colonizers. They come and they get cleared later. So what if that woman is not having it at that time? So you need to check if the person has actually had those uh the bacteria colonizing the vagina at that time, because it can infect the neonate. It can infect the neonate. You remember what group B strep can cause. It can cause neonatal pneumonia, it can cause meningitis most importantly, and it can cause neonatal sepsis. So meningitis, pneumonia, sepsis in that neonate, very important. Then E. coli 2 is in the vagina. Then lactobacillus. Lactobacillus is the primary one that you first remember, because that is how we can explain the pathophysiology of bacterial vaginosis. Bacterial vaginosis. So that has the bacterial vaginosis is due to the fact that there's death of this lactobacillus. There's nothing to generate acidic pH in the vagina again, and the pH of vagina becomes more than 4.5, and you have the Gardnerella vaginalis and other microbes in the vagina proliferating, causing bacterial vaginosis. So, what are the bugs that cause football illness? We already know this, and we've said it. The Staphylococcus aureus enterotoxin, as well as the exotoxin of the Bacillus cereus, they cause rapid onset food poisoning that happens within like 1 to 2 hours after you consume the toxin. You have the diarrhea and it resolves. That is that. How do you typically get the Staph aureus one? Okay, they'll still mention. Okay, yeah, we mentioned it. So let me just go accordingly. So for the Bacillus cereus one, we typically get it when you consume irritated rice. So once you see irritated rice in the question, you know what they are talking about. Bacillus cereus, very straightforward.
So
For
does it mean that if they say we are salad, it cannot be Bacillus aureus? Yeah,
No, they will
serious.
not typically use salad for Bacillus cereus. They will want to use salad for like Staph
Mm-hmm.
aureus. They can use
Mm-hmm.
salad for like Staph aureus. But this Bacillus cereus, irritated rice, is rice. Is rice. Because you can't reheat. Do you typically warm salad? Mm, maybe
No,
microwave.
no, no.
They don't warm it. They don't warm it. So it's what you reheat like rice, that because that heat is what is actually allowing it to germinate. So Clostridium botulinum, two forms. The preformed one and the spore. The preformed toxin and the spore. The spore is for neonate or babies. The preformed toxin is for adults. So preformed toxin for adults, spore for neonate. So that is why adults can develop the infection almost immediately, because they usually consume the prevent toxin from consumption of canned food. Improperly canned food, they can develop. Or raw honey, eating, all these babies can, consume raw honey. They can consume soil, and you can have that spores in the soil. You can have the spores in the raw honey. So it will take time for it to manifest. But once you are seeing rapid onset botulinum, um, it can be from canned food, and in adults, adults are the ones that usually take this canned food. Yeah, so don't forget that. And we remember the way Clostridium botulinum will present the D's, dysphagia, diplopia, descending paralysis, dysatral, and all those things. Once you are seeing those paralytic symptoms, you know that this is botulinum. Clostridium paphryngeis, reheated meat. Okay, fine. So Bacillus cereus is for reheated rice, paphryngeis is for reheated meat. The most important thing about paphryngeis is just to remember that this guy can cause gas gangrene. Can cause gas gangrene, foul smelling discharge. It can cause diarrhea too, that typically resolve in 24 hours. You guys remember Clostridium paphryngeis, Clostridium paphryngeis, gas gangrene, and diarrhea that can resolve in 24 hours. E. coli 0157H7 strain. That's the one that causes the enterohemorrhagic diarrhea. And that is one that is also implicated in causing our hemolytic uremic syndrome due to the elaboration of the Shiga toxin. Very important. I don't think the mechanism that way you get that one is important. No. By the time they paint the history and they tell you what is happening, you already know the organism that they are talking about. So Listeria monocytogen, deli meat, yes, soft cheese, yeah, unpasteurized milk, so many. But of course, we are going to see. We can see the granuloma infarctiseptica, the rash in the baby. They can talk about neonatal meningitis. They can talk about chorioamnionitis. They can talk about spontaneous abortion in the mother. They can talk about self-limiting diarrhea in the adult. This is likely to be Listeria monocytogenes. Do you remember the treatment we give for Listeria monocytogen? Anybody? Do you remember? Anybody? One single drug, just give it, we move. Listeria. Do we remember? Okay, we don't remember. Ampicillin. Ampicillin is what we use for Listeria monocytogen. Ampicillin. So Salmonella. Uh, bloody diarrhea, salmonella. You can see the rose-colored rash, the road spot. Yeah, and it typically presents with constipation first before diarrhea. Constipation predominantly because we said it that it causes hypertrophy of the Peyer's patches. So you can get it from meat, from poultry, from animal diet. Typically, it's gotten from animal sources. Salmonella. Remember constipation, bloody diarrhea, rose-colored rash. Um, uh, uh, what else again? Um, what was it? I think that's essentially, yeah. So they can also have this um temperature pressure pulse temperature dissociation. So yeah, something that looks like the Faggot sign. So they have this relative bradycardia. Yeah, so the temperature is increasing, but the pulse is not increasing commensurate with the temperature. So that's also a pointer to salmonella infection. Staph aureus, you get it from eating mayonnaise. They like using this mayonnaise very well. Staph aureus. So mayonnaise, the custard meat, if the person takes in the toxin, you can have, you know, the Staph aureus infection and, present so many ways. Then uh, vibro parahemolyticus and vibrofunificus. Those two, they are seafood, so they like using it as shellfish. So vibrohemolyticus, parahemolyticus can and the vibrofunificus they can cause this, particularly the vunificus, it can cause wound infection. So someone that is handling all the seafood and shellfish, they can, and there's an injury to the hand, they can easily inoculate into that injury and they can cause wound infection. So don't forget about that. Vibro and diarrhea. So the bloody ones we already said them. Campylobacter, uh, entamoeba, enterohemorrhagic, all these guys. So Campylobacter causes diarrhea too, bloody diarrhea for 2 degree. And this diarrhea for Campylobacter is very common in the children. So once you see a child having diarrhea, that is Campylobacter, most likely that is bloody. Then they typically grow at 42 degrees Celsius. Yeah, 42 degrees. Yeah, and of course, they are oxidase positive. We should remember that. They are comma shaped, they grow at 42 degrees Celsius, and they are oxidase positive. Bloody diarrhea, Campylobacter. They can be gotten from exposure to pets, dogs, cats. They can be gotten from consumption of unpasteurized milk, Campylobacter jejuni. Amoeba histolytica, two major forms, can cause amoebic dysentery, that is bloody diarrhea, as well as liver abscess. So it's a protozoa, and you can give metronidazole to take care of the what's it called, the invasive disease, but the one that's still located within the colon, containing the trophozoite, you want to the cyst rather, the cyst in the intestine, you want to eliminate the cyst by giving paromycin or hydroquinone. So those ones will prevent the cyst differentiating the trophoblasts to cause the um the what's it called, the invasive disease like the liver abscess. Yeah, so we should not forget that. Enterohemorrhagic E. coli, we've talked about that. HUS, Shiga toxin. Enteroinvasive, which also cause blood diarrhea and they invade the colonic mucosa. The Salmonella, the non-typhoidal, okay, they're lactose negative, all of them. They don't ferment lactose. They are mobile, yeah. Animal reservoir. This one is not high you. They already ask us non-typhoidal stuff, yeah. So they usually cause this self-limiting diarrhea and they are gotten from animal reservoir. Shigella is just like Salmonella too, very similar, but just that Shigella be presenting with crampy abdominal pain. And then we have this bacillary dysentery. You have bloody diarrhea, crampy abdominal pain. That is very mucoid. So once you see that, it's likely to be Shigella infection. And Shigella just need very low dose, very low dose. That's what you need. That's what you need. And once you give the antibody, you kill off the once you give the antibiotic, kill off the organism. It doesn't typically shed it in the colon. Yeah.
But Dr. Baba, can you
Yeah.
really differentiate presentation of this Shigella and the enterohemorrhage?
Yeah.
Sorry.
So enteromyalgia, they usually link it to HUS. So they'll
Okay.
start giving you the renal picture, they start giving the platelets, they'll start giving a diarrhea. You know
Okay.
that this is likely
Okay.
to be enterohemorrhagic.
Oh, and then I think Shiga doesn't have fever. I think so. I think I've seen it.
Shiga toxin. Wow. Well,
Uh,
I'm
I
not
think I've
aware of
seen it.
that. I'm not aware of that. So yeah, so Shigella, So very low dose, just need very low dose inoculum to start the infection. It also uses the Shiga toxin. So Shiga toxin from Shigella can also cause HUS. Please, you have to be careful. It can also cause HUS, but HUS is very common for the heterohemorrhagic. So animal reservoir only for Shigella. Animal reservoir only for Shigella. Uh, it can cause bacillary dysentery. We talked about it. Crampy abdominal pain, mucoid stool, then blood diarrhea. Then Yersinia enterolytica.
Dr. Baba, what am I even saying? I just remember now that HUS2, there is no fever in HUS2 now.
There's no,
Fever in HUS, right?
no, I said I don't know. I don't know.
No, I'm just saying. I think it's HUS doesn't have fever. When we compare HUS and this ITP, thrombocytopenic
Oh, I
purpura,
get what you're
that's
saying.
one. That's the one that has
But
fever, right?
I don't think that's a clincher like that. They were just saying TTP has fever and cause neurological symptoms. You get in addition to the
Mm,
triad. So, but the thing is, fever should not be a decider. Do you know why? Both of them are infection.
mhm.
Both of them are infection.
Okay.
So there's a possibility, but
No, I know. I'm trying to correct myself that I can't use fever to differentiate between
exactly,
enterohemorrhagic and Shiga because even enterohemorrhagic too, they said, I mean, there is no fever like that too.
yeah. Oh, I even thought you were differentiating from HUS and TTP. Okay, okay, yeah. So Yersinia enterolytica um can cause bloody diarrhea too. So it can mimic appendicitis because it causes inflammation of the mesenteric lymph node as well as the Peyer's patches. The sorry, not the Peyer's patches, the terminal ileum. So it can cause terminal ileitis that's very close to the sacrum. So they can have this lower right quadrant pain. Then it can also which can also mimic appendicitis. It can cause inflammation of the mesenteric lymph node and it can cause a bloody diarrhea. It can also cause reactive arthritis, Yersinia enterolytica. Yersinia enterolytica. Okay. Then watery diarrhea, those are the ones that cannot cause bloody ones. So Clostridium difficile, which causes pseudomembranous colitis that can easily progress to toxic megacolon and the colon can rupture and it's usually caused by antibiotics and PPI that suppress the acid and allow this guy to grow. Antibiotics also suppress the normal flora and to allow this guy to grow. And we talked about the two toxin, the cytotoxin A and B. So we should not forget both of them. They inhibit the formation of the actin filament. So they destroy the cytoskeletal architecture of the cells. The epithelial cells of the colon. So that's the mechanism by which they cause the diarrhea. So they disturb the activity of the epithelium due to paralysis of the actin filament there. So occasionally they can cause bloody diarrhea. Okay. Papharynges cause gas gangrene. We said this before. Enterotoxigenic is notorious for causing travelers diarrhea, and it uses these two toxins, the E stable and the E labile, which increase the activity of our CMP. So we should not forget that the increased CMP that increase secretion of sodium and chloride in the stool. Then protozoa too that can cause bloody watery diarrhea, Giardia and Cryptosporidium, both of them. Giardia, you are going to see multi-trophozoite. Cryptosporidium, we see the oocysts in the stool and it is acid fast. Both of them will cause watery diarrhea. And Giardiasis typically affected with steatorrhea. So steatorrhea too, foul smelling, bulky stool, you know, abdominal cramps, giardiasis, cryptosporidium, acid fast oocyst, cryptosporidium is responsible for that. Then vibrochlorid, comma shaped, can cause rice water diarrhea. The diarrhea is usually very massive. Rice water, they are vomiting, they are having diarrhea too. So, from infected seafood, because it's vibro, seafood is very common for the vibro. Then viruses, noro, can also cause watery diarrhea and it's very common in developed country. The incidence of rota has reduced in developed country because of the vaccination. So, watery diarrhea in children can also be due to this adenovirus. So, it's one of those um, enterovirus that we talked about, you know, adeno. So, yeah. So, the most common cause
And
now, the most common cause now in developed country is noro. So, rota has reduced. Rota is even very common in children and has reduced due to vaccination. So we should pay attention to that with respect to the watery diarrhea. The watery diarrhea one is
So
very easy. Yeah,
Dr.
I'm
Baba,
listening.
listen, when they say sudden diarrhea after eating something, and we can't say viruses, right?
No, we can't say viruses. Though. It's not a virus.
Okay.
So it's likely to be maybe Bacillus cereus or um, Staph aureus.
Enterotox, eat table stuff.
Yes. So one of them. So the pneumonia causes, these ones, they don't really ask. It's not very high, but we should just pay attention to the ones for the neonate, that the neonate, particularly those ones that are less than 4 weeks, they can have pneumonia caused by the group B streptococcus, just like we said, and E. coli. These two are very common in people that are young. These two are also implicated in causing meningitis in the neonate, group B and E. coli. Very important. Then, so I don't think we actually need to learn all these other ones, honestly speaking. I don't think we need, but we can move
Maybe
from,
the 4 to 18 years too now.
yeah, 4 to 18 years. These are atypical
I mean,
guys. These are atypical guys. The way the question will come, you already know what they are saying. So most likely, when they say someone is having uh, pneumonia symptoms, having cough, having difficulty in breathing, uh, chest pain, and all those things, and the person is also having diarrhea, the person's having diarrhea, the person's having, abdominal pain. So you might be thinking one of those atypical guys, maybe mycoplasma or something. So they typically present that way, and um, they also tell us the X-ray. So they will tell us the finding on the X-ray, and of course we've said it that the finding on the X-ray will be terrible, and it should not be in keeping with the presentation of the patient. So the patient might not be that bad, and the X-ray will be terrible. So there will be a way that's why I'm saying once you get ourselves exposed to questions very well, we'll be able to figure out how these things actually come. So, but I'm not really sure I've seen too much question on testing the specific organism that causes pneumonia. Because the way it comes, we'll be able to figure out what they are talking about. So, yeah. So in adults, you want to look out for strep pneumo, influenza, then the H influenza. So I think those are the important ones to note. Just know the neonate one, then maybe in the adult. Yeah. So what are the special groups? So for alcohol, for people that are taking alcohol, CLEB is number one. So we've already said this. CLEB is number one for alcohol. So people that are taking alcohol can become unconscious, they can lose consciousness, and they can easily aspirate. So they can have um um you know respiratory tract infection from inhalation of these anaerobes. So they can have lung abscess from these anaerobes like Streptococcus, the Fusobacterium, the Prevotella, and the Bacteroides. So those are the two guys that can be present in lung abscess in someone that's use of alcohol. Yeah, the one that is directly related to the alcohol is actually clear, but the one that is due to the aspiration are the anaerobes. Streptococcus, Fuso, Prevotella. I know that we have said this before. So somebody that is taking drug, injecting drug, you know, developing respiratory tract infection, it might be due to strep pneumo and staph aureus. Very, very important, especially staph aureus. We said the staph aureus, candida, pseudomonas. Those are the things that causes infective endocarditis in people that are taking drugs. So people that are taking drug too can have infection, particularly from staph aureus because it's present in the skin. Yeah, so it can get inoculated from the um the needle and something and get inoculated into the blood from there. So people that have aspiration, maybe for the fact that they have a stroke, they are just unconscious, they cannot control the airway, for many causes, they typically have problems with the anaerobes. So the atypical organisms, they are these Mycoplasma, Chlamydophila, Legionella. So if it's going to be Legionella, diarrhea is very common there. They can have neurologic symptoms, they can have encephalitis, they can have diarrhea, they can have the typical respiratory symptoms for Legionella. So chlamydia, pneumophilia is not very common. They like asking chlamydia with respect to all those lymphogranuloma venereum or the PID. That's where they like ask. They rarely ask chlamydia for pneumonia. No, very rare, very very rare. They can ask RSV for bronchiolitis in children. using the F protein that we talked about, the fusion protein. So CMV can also cause um, pneumonia and respiratory tract infection, particularly in people that have immunosuppressed or transplant patients. So we want to watch out for the triad of CMV. In fact, it's not a triad, it's like a pentad. More than pentad itself. It can cause encephalitis, it can cause pneumonia, it can cause retinitis, it can cause colitis, it can cause hepatitis, it can cause esophagitis. So CMV is a very bad guy, particularly in people that are immunosuppressed. So influenza too can cause pneumonia. So it can cause pneumonia, and the pneumonia in influenza is usually superimposed by bacteria like Staph aureus. So those are the ways they can ask those questions. Yeah. So um, cystic fibrosis, we should watch out for these three. Me, I don't really like talking about this strep pneumonia. Most importantly, Pseudomonas, Staph aureus, and Burkholderia cepacia. So this Burkholderia cepacia, when somebody has cystic fibrosis, they can get this guy, and you don't transplant the lung that has this Burkholderia cepacia to another person. It will fail. It will fail. The infection will become overwhelming, so you don't use it. Once you screen for this guy and it is there, you don't transplant that lung again. So Staph aureus is particularly in young people, then Pseudomonas in adults. Yeah. So immunocompromised individuals can also have develop all these lung problems. So from Staph aureus, you can have pneumonia from there. Then most importantly, pneumocystis jirovecii. That's the one that they will ask. They will not have from virus, they will not have from fungi. Okay, they might have from fungi, but most importantly, pneumocystis jirovecii. So they will tell us the person has a CD4 count that's less than 200, and the person is having pneumocystis jirovecii. Features like this low grade fever, having chest pain, difficulty in breathing, and we did the um, radiography. We could see uh, ground glass appearance, ground glass opacity. That's likely to be pneumocystis jirovecii. Or they did the methanamine stain, they were able to see the disc, yeast, disc like yeast. Those are the common ones. Those are the those are the important things that you can see. It's good to know all these things, but common things. We major on the major. So those are the major things I want to look out for. Yeah. So the healthcare associated, you know, pneumonia, pseudomonas, yes, yes. So people on mechanical ventilation, they can so people on mechanical ventilation, they can have this pseudomonas infection, you know. Uh yeah, so because it can form the biofilms, in people that are exposed to mechanical ventilator. Staph aureus too, yeah, because it's nosocomial. Staph aureus it's just everywhere in the hospital. Yeah. So post-viral, we've said it, post-viral like influenza, it can be any one of these, but most common is Staph aureus. Most common is Staph aureus, particularly after influenza infection. Then COPD, strep pneumo, most importantly, strep pneumo, because um you give vaccination for strep pneumo in people that have COPD, and you know influenza too. But it is not this influenza. I don't know why this viral influenza is not here, because it should be here. It is not actually this influenza, it's the viral one that you give vaccination to people that have COPD, because they can provoke exacerbation of the COPD. So these ones too can come in and cause pneumonia in them, sha. Yeah. But the one that you're actually very scared of is the strep pneumo, as well as the viral influenza. Yeah. So meningitis, yeah. So I feel we need to pay attention to this. In newborn, we should be worried about the group B streptococcus, the E. coli, and listeria. Those are the three. So it's just like in newborn in pneumonia, group B streptococcus and E. coli. But here we're adding listeria to it for meningitis. Then the children and the 6 to 6 years, they are pretty much very similar. Those three major ones, those are the ones they can ask. So strep pneumo, Neisseria meningitis, and Haemophilus influenza type B, very classic. You have that from 6 months to years to 60
Mhm.
years. Both of them are present. It's just that in elderly, you have you just remove E. coli. So you have group B and Listeria still in elderly. Group B and Listeria in elderly. So E. coli is only for newborn. But group B, Streptococcus and Listeria, they are both for newborn and for adults. While the other ones, remember strep pneumo, meningitis, and H influenza. H influenza. And remember that HSV too can cause meningitis, particularly the type what? HSV type what? Meningitis. Hello, you guys have
HIV
forgotten.
type 2, type 2.
Type 2 can cause meningitis. So type 1 causes
Temporal encephalitis or something.
temporal lobe encephalitis. Yeah, so to treat the meningitis, because you usually use this ceftriaxone and vancomycin. So we use uh you know, especially for this what's it called? This strep pneumo, the Neisseria, you have to use ceftriaxone. So you can use your ceftriaxone and vancomycin for those gram-positive organisms like strep pneumo. You have to use ceftriaxone for the gram-positive like our group B strep, strep pneumo, because they are the common one that causes meningitis. So you give ceftriaxone or vancomycin. Then if you are thinking listeria, you want to add ampicillin. You want to add ampicillin. So for the viral causes, so that means that this ceftriaxone is going to take care of our strep pneumo and is going to take care of meningitis. Yeah. Influenza type B is not common again for meningitis. We know why. There's already vaccination for that. So it's the non-typable one that is now dominating and causing problem now. But those ones typically cause uh the sinus problems, mucosal problem like sinusitis, bronchiolitis, otitis media. Those things that those ones cause. They don't typically cause meningitis. So, for the viral cause of meningitis, we think about the aseptic meningitis. Those the coronavirus that cause aseptic meningitis. So the patch, the patch, the patch, the patch. So the what's the first one? Polio. The second one is Echo, and the third one is Kozaki. So polio, Echo, Kozaki. Those are the enterovirus that can cause meningitis. So we already know the way they will present Kozaki. So if we want to talk about the Kozaki A, we can talk about fever, they can talk about angina, vesicles in the mouth, fever.
Mhm,
They can talk about the person having rash involving the hand
mhm.
and the sole and the
Foot.
palm. Yeah, you know that that's likely to be Kozaki type A. It can also be a cause of viral meningitis or aseptic meningitis. So the HSV2 can cause meningitis. HSV1 is even here. HIV can cause meningitis too. Western Nile can cause meningitis. Western Nile can cause meningoencephalitis as well as asymmetric flaccid paralysis. So once you see that asymmetric flaccid paralysis with meningoencephalitis, one of your differentials should be Western Nile. It's just like polio, meningoencephalitis and asymmetric Western Nile virus, Western Nile virus, Western Nile virus. So and
And asymmetry what?
asymmetric flaccid paralysis.
Okay.
So what's the family for Western Nile? Let me see if we can remember. What's the family for Western Nile?
It's with all this Picona.
Hmm.
Is with no. Is with
Fla-
Zika. Is with
Flabby.
them.
Yeah. Is it Flabby or
Yeah,
Philo?
Yeah,
probably.
it's Flavi. It's Flavi. So that's the
Mm,
one
Flabby.
that we said HDWYZ.
WXYZ.
WYZ, exactly. So it's,
YZ.
it's a Flavi. Flavi. Western Nile, don't forget. Very similar to polio in terms of presentation. Meningoencephalitis, asymmetric flaccid paralysis. Then varicella zoster too can cause encephalitis. Yeah, meningoencephalitis, varicella zoster, very important. That they can also cause pneumonia too, varicella zoster. Those are the viral causes of pneumonia. HIV. So someone that has HIV and the person is having meningitis, you are suspecting your cryptococcus, very high yield, very high yield. Tip capsule, you can stain the capsule with your periodic shift nib. You can look at it with Indian ink. We can, what else again? That's a tip polysaccharide capsule. Very important point for, and you don't forget the Indian ink stain. You should not forget the Indian ink stain. So, um, uh, what other stain do we use? We use another stain again. Um,
Must say, am I? Is it the one produced there?
the color will appear red with that stain. It's going to appear like
Mm,
red.
the Avil is not the Mosiramine, I've been
Yeah,
Mocaramine. What?
musicamin. Yeah, musicamin. Cryptococcus, musicamin. So, um, so the incidence of group B streptococcus have been reduced because of the screening. Yeah, and we said it. And giving the mothers the antibiotic prophylaxis, just giving the ampicillin, they are okay. The ampicillin, they are okay. So the incidence of H influenza, you can see they even mentioned it here because of the vaccination. So we don't get to see H influenza meningitis too again. So the cases today are now seen in unimmunized children. Yeah. So what are the CSF findings in meningitis? Once we see this, we should be happy. This is bonus question. So the first thing I will always look at is the glucose. That is the first thing I look at. So once I see CSF analysis, I look at glucose. Once glucose is low, that is bacteria or fungi. Don't worry yourself. But it is not very common for us to give us fungi. So once you see that glucose is normal, virus, glucose is low, it can be bacteria, fungi, or TB. So what will now separate fungi and TB are like the same. So what will now separate them from bacteria is you checking the cell type. So for bacteria, you are going to be seeing the polymorphonuclear leukocytes, particularly the neutrophils. Those are the ones that will be there. But fungal and TB, it will be lymphocyte that will predominate. Yeah, very important. So all of them can elevate the protein. Protein will be more than 45 milligram per DL. It can be more than that. Glucose can be less than 60 for any of them, particularly the bacteria, the fungal, and TB. So virus is usually normal in terms of glucose. Protein can be elevated or normal in virus. Then, of course, what will predominate in the virus is lymphocyte too. Yeah, so those are the clean charts. Once you see for bacteria, opening pressure can be elevated. Cell type is PMN, that's the neutrophils. Protein is elevated. Glucose is down. So once you see glucose down, you know, and then there's neutrophil, that is bacterial meningitis. Once you see glucose down and there's lymphocyte, it's either TB or fungi. Once you see protein high, glucose normal, lymphocyte predominate, that is virus. So virus and fungi and TB have lymphocyte. It is only bacteria that is neutrophil. So that is that. Then infection causing brain abscess. So most of them are usually this viridian strep and the staph aureus. Those are the things that typically cause brain abscess. It can also follow someone that has a dental infection. So they can ascend, from the sinus. They can go to the olfactory. From the sinus, they go to the eye. Then they travel to the frontal lobe. Some of them can pass from the mastoid. So people that have this mastoiditis typically have the spread to the mastoid part of the uh, because the mastoid bone is actually part of the temporal bone. So from there, it can ascend to the temporal lobe of the brain and the cerebellum just at the back. So once you see history of mastoiditis, the area that will typically affected is the temporal lobe because the mastoid process is part of the temporal bone. So it can spread to that bone and from there get to the temporal lobe. So don't forget that. Don't forget that. So once you are seeing somebody having brain abscess and the person has done a dental procedure extraction, we are thinking it's oral anaerobes that have ascended, to the brain. So they can pass through all these planes. I think we talked about it then. There's some facial in the neck, that they can pass through from the mouth and go to the brain. So dental procedure can cause dental abscess too. They can cause brain abscess too. And they are typically the oral anaerobes in the mouth. So, the disseminated one, from the blood are usually from Staph aureus and the Viridan's Staphylococcus. So, um, yeah, so that is that. So sinusitis, yeah, so yeah, exactly. So sinusitis and dental infection too can go to the frontal lobe. So from the sinus, they can go, they can ascend through of the cubicle plate to get to the front, to get to the, frontal, because you know that the olfactory nerves are just below the frontal lobe. So if it ascends through the nose, they can get to the frontal lobe, or it can pass to the eye, and also get to the frontal lobe because the eye veins they are drained by the cavernous sinus, then you can take it to the frontal part of the brain. So once you see mastoid, it's temporal. Mastoid, temporal and cerebellum. temporal and cerebral for mastoiditis and otitis media. Those ones in the hair. So from the
Which
hair,
organism is indicated for that one? Mastoid.
so it can be any one of them. It can be the Viridians or the Staphylococcus aureus. We don't have any, precise organism that is.
Why was I thinking that maybe it's from the hair or something? Not that one.
Yeah, it can be from the hair. Anything that causes otitis media. We have so many things that
Okay.
can cause otitis media. So all those MOPS that we are saying. So what's it called? This our strep pneumo can cause that. Hemophilus can cause that. What other organism? So any organism you can think of, particularly that for otitis media, you know, it can come from all those organisms that can come with MOPS. So strep pneumo, hemophilus, they can cause otitis media that can get spread to the mastoid bone. Then from mastoid bone they are sent to the brain and cause that. So, but the most common organ that you culture from all those brain abscess is actually the viridians and the staph aureus. Yeah. So another cause of brain abscess, this is the one that they usually like asking. So this toxo. Once you see that it's multiple brain abscess, someone that has eight is likely to be toxo. So osteomyelitis, um, so the most common infection for osteomyelitis is staph aureus. Someone that is sexually active and is having osteomyelitis is likely to be Neisseria gonorrhoeae, although it's rare, but it can have the disseminated form, which can, cause, that can go to the joint and cause osteomyelitis. Although septic arthritis is very common, so it typically affects the joint. You see purulent effusion in the joint, there's tenosynovitis, there's this disseminated rash in the body, pustular rash, disseminated Neisseria infection. So people that have sickle cell, it can be staph, most commonly staph, but the incidence of salmonella too is very high, very high. So prosthetic joints, those ones that you can get from the skin, particularly strep epidermidis. We said,
Dr. Babali, sorry. The sickle cell thing. This has clarified because I think I've seen a question on it before.
mhm,
So I think what I remember is that staph aureus is a very common cause of
mhm,
osteomyelitis and sickle cell disease,
mhm,
and so is salmonella. But
yeah,
even yes, I've just remembered. Sorry, but even with patients with sickle cell,
mhm,
staph is still higher
yeah,
than salmonella.
yes, that's exactly what I said. You know,
Okay,
staph is still the
okay.
commonest. It's still the
I just remember it
commonest.
was a question that you confused me or some other
Yeah,
people, so I just wanted to clarify.
exactly. You will not
Okay.
still pick salmonella. You will not pick salmonella. Once you see staph aureus there, you will not pick salmonella. It's the commonest overall. Look at the first statement. Staph aureus is the commonest overall, regardless of the situation. It is staph aureus.
And I feel they won't put those options, the two options together.
Even if they put it,
And
it's
they,
still staph aureus that they will put. They've put it. I think they've put it together before. So that is
They actually put it
how.
in the question. Yeah, so that
Yeah,
was the confusion.
that was the confusion. So it will be there. It will be there.
okay.
So, but the incidence of salmonella is just high in sickle cell, compared to the other population. But it's still staph aureus that is the highest overall. So prosthetic, we've talked about this. Anything prosthetic, you want to look for epidermidis, prosthetics. Uh, prosthetic joint, staph epidermidis, staph aureus can also complement, can also colonize it. So for vertebra, both of them. So someone that has this abscess, psoas abscess, you know, it can be from the vertebrae. So from osteomyelitis of the vertebrae, they can spread to this the psoas. You guys remember when we were doing our musculoskeletal, we're talking about that psoas abscess. Yeah,
Mm-hmm.
saying you want to aspirate and do the analysis that it can either be staph aureus and microbacterium because both of them can actually affect the spine. So it can spread from the vertebrae to the thigh and cause psoas abscess. So once you see vertebral osteomyelitis, you're actually trying to rule out TB and staph aureus. So cat and dog bite, that's just Pasteurella multilocuta. So once you see dog bite, most commonly Pasteurella. So I think there's one question like that in UWorld about this Pasteurella, dog bite, and all those causing osteomyelitis. Then injection drug use. So those three that we have always talked about: Staph aureus, Pseudomonas candida. So in osteomyelitis, because an inflammatory response, ASR is elevated, CRP is elevated, but they are not specific, but they are sensitive. So once there's inflammation, there will likely be elevated, but they will not tell you the kind of inflammation that is happening. So radiographs are very, very useful, particularly for chronic osteomyelitis, where you see those discharging sinus tracts. Once you see it on X-ray, discharging sinus, okay, this is likely to be a chronic osteomyelitis. And you can also see the, sequestrum, being within the involucrum and all those things. Then MRI is best to detect acute infection before you use your, what's it called, your X-ray. You can use MRI because MRI has a very good tissue resolution, so you can see the tissues, you can see the collection anywhere, in MRI. MRI is very good for our bone and tissue analysis. So you must biopsy and aspirate. We've said that you must biopsy and aspirate to know the organism that's actually there. That's the only way you can find out. So what are the other things that can elevate ESR?
Giant cell arteritis,
Okay.
polymyalgia,
Mm.
infection,
Mm-hmm.
what else? Anything that increases the distance, polycythemia.
Adrenaline.
Yes,
Polycythemia will reduce.
it will reduce it, yes.
Anemia,
Anemia,
infection, malignancy, pregnancy, end-stage renal disease, nephrotic syndrome.
Why is pregnancy increasing it?
So you just link pregnancy to dilution anemia.
Okay.
There's plasma volume expansion. Okay, guys, so you guys should go and rest. Abi, you are resting now.
No, I'm 6 now.
Okay. So
Let's do quick, Dr. Lawley, please.
we're almost done, Sha. Well, I shall pray you guys be able to remember. Well, you guys are still going to go over it on your own, so it's not a problem. So
Do you want to do like a 5 or 10 minutes recap? And
of all we have done,
Someone said, what is rest? Today, what we've done today.
So yeah.
I think it's not so not so bad. So
no, wait,
so
I don't
we
understand.
for
What are you saying, Dr. Toby? Like what we have done?
No, Bisola said what is rest. I said
Okay.
we can go over we can just do like a 10 minutes
Dr.
quick
Bisola,
recap, like one of us.
Dr. Bisola, just relax though. You need to rest. You guys should sleep, oh. Please, oh. Sleep is important for consolidation of memory. If you don't sleep, you cannot consolidate what you have learned. Please. I feel you guys you guys just need to revise. All what you have known is sufficient enough to allow you pass. So you guys just need to just revise. This is not the time to now be killing ourselves and be what is there? We should just this is not step 2. This is step 1. So we will pass. It's not a big deal.
No, but somebody that is getting 30, someone that is getting 30 consecutively in NBME. What's the chances of it?
Sorry. Thank you, Dr. Zuliat. So hand and mouth. Hand and foot. Hand and foot and mouth. Oral shaped vesicles in the palm, in the sole, and in the oral mucosa as epangina. That is that about the Kozaki. So Kozaki type A is very easy to palm and can also cause what problem in the heart?
Myocarditis. Viral myocarditis.
And what again?
Can it cause pericarditis
Yeah,
too?
it can cause pericarditis too. I hope you guys are able to palm diagnosis of pericarditis final level now.
Friction rub, leaning forward. Forward. Like, are you trying to ask us the causes? Like, all the causes that can cause
You said diagnosis now. Diagnosis.
Okay.
So, Babali, what else do you want to hear?
Yeah, no, you're okay. I'm okay.
Okay.
So, low voltage ECG and all those things.
Yes, low voltage, because it is away from the chest wall. The heart itself is away from the chest wall, so you will not see those waves like it should be.
Yeah, so
Yeah.
our cardio must be solid. Dr. Bisola, hope
Dr.
you have
Bisola.
revised cardio very well. Dr. Bisola. Oh yeah, cardio ẹ̀ ti máa gbá báyìí o.
It's not bad. It's not bad.
So
But we just
make
need
sure-
like revision and
make sure
like
that cardio is tight.
key. How do I call it? What do I call it now? Key revision kind of
I understand.
thing.
Like I liked the point.
For
very well.
example, there was a question we were solving in our midst. This thing, what was it about? This opening snap thing
Okay.
that we're talking about.
Mhm.
So they simulated S3. They said there was an early diastolic sound,
Okay.
and then they were like, "What is likely to cause it in this patient?" So. Amidst the options, there was mitral stenosis, there was mitral regurg, there was mitral valve prolapse, and then other valvular issues. And so it was early diastolic sound. And yeah, I think that was the major thing. So it just made sense. S3 shows rapid filling of the ventricle. So the way I now try to explain it, because it was clear, I understood the whole thing, was that with mitral stenosis in the mild and moderate stages, the atrial kick, that last diastolic phase, where the atrium is supposed to push out blood into the ventricle, the stenosis valve builds resistance. So the atrium has to mount up enough pressure to open the stenosis valve leaflet. So by the time the valve is closing back, it is giving us that loud sound that we are hearing. So that's how, like,
Dr. Toby, I hope you are not mixing up two questions together. For the early diastolic one, it was more of like they were telling us the patient was lying left lateral recompetent and they had a murmur that was
it's still
louder.
the same thing. It's still the same thing. It's still the same
Was it
thing.
the
The
same one?
S3 is the same. You know why?
Because
That
I think the
maneuver.
answer we chose was
Yes.
mitral regurgitation for that one.
Yeah,
Is
that should be mitral
mitral
regurgitation.
stenosis.
That should be mitral
You're
regurgitation.
mixing up two questions, Dr. Toby.
Dr. Toby,
You have mixed up
mitral
the two
regurgitation will
questions.
cause volume overload and it will give S3. That's correct. And you can hear it when you place the patient on left lateral decubitus, just like S4 too. Both
It's
of them.
louder, yes. That other one that you were talking about, the snap something, that's not how they
Is
put
that
the question.
severity? Is it severity? Is it like severity?
No, it was not even severity. It was more of like they gave us. They were like, why is it louder? Like, I don't even. Dr. Olushola, can't remember that question. It was so we're in between aortic stenosis or aortic. Me, I was like, okay, this is aortic regurgitation, but you now explain to me that this is aortic stenosis because of the valve is stenosed. That by the time we are using a high pressure to open a thickened valve, by the time it's closing back, it's going to give a very loud sound.
Yes.
You understand? That was what you explained.
It's going to.
Do you understand,
By the time
Dr.
they use
Toby?
pressure to open it, it will snap back. Bam. That is the opening snap. So that increased pressure initially that I want to open it with, that's what is causing the opening snap. Because if there's no stenosis, you won't have the opening snap. It will be free to pass through. But when there's an obstruction and you are now trying to force it, it is when that force is now kind of more than the obstruction. That's when you now hear the snap. Bam! Like it has given way. So that it can now start feeling. So.
Oh yeah, it went out, Jerry.
Okay, maybe Dr. Oluwatobi has gone to look for it. But that's why
Yeah,
I
I'm
was
trying to look for it. Yeah.
That was why I was trying to carefully listen to her. But you know,
because I'm trying to understand what I'm coming. Let me see. I understand.
Yeah, I know what you're
I'm
saying,
mixing
but
up
I know we did two
this
questions
thing.
that day, so you've mixed the two questions together.
no wala. But
Okay.
Dr. Zula, what were you saying the other
See,
time?
Dr. Oluwatobi, once you see S3,
Look,
it is volume overload.
do you know that question about aortic stenosis, the snap that is loud? What was that question? Can you help us? Like, can you